Jen and I are like super excited to host and facilitate the discussion today with Dr. Jackson as part of this shelter-in-place seminar series that we've been having for the last 2 or 3 months. I have to say that I am personally very excited about this talk because I know that like other people here, I've been learning a great deal of things from Dr. Jackson on Twitter and through his publications, but this is actually my first time ever hearing a presentation from you. So we're very grateful you were willing to give this talk today. And so as we've proceeded in previous iterations of the series, Dr. Jackson will start by spending the first part of the talk discussing his work and his work notably as the founder and executive director of the Community Access Recruitment and Engage Research Center. And then in the second half, he will be talking a little more specifically about his own career development and past experiences like we've done before. So just like Jen said, we'll be recording this, so you can hide your face now if you want to. And please remember to mute your mic and interact in the chat during the presentations. Here you go.
All right. Thank you so much to Jen and Renaud for inviting me. I know that Renaud got in touch with me months ago to schedule this talk. So I feel like in the month of June, when we're talking a lot about research, whether our research is shut down or whether it's resuming, we're talking a lot about race and kind of the perception of race and how that influences our research. I think that this talk should be fairly timely, and I'm hoping that it is intriguing. It's certainly a big swing at the very least. So we'll see how it is how it's received. So if you give me just a minute, I'm going to pull up my slides and we'll get going. So my computer's a little sluggish today. Hopefully everyone can see. Are you looking at? Hopefully you're looking at the regular view and not the presenter view. Great. So this is an abbreviated version of a talk that I give. Normally, it's hard to get this talk in about 60 minutes. So I've cut it down to about 25. So you're not going to be able to see everything. And we're going to have to kind of take a few leaps, but hopefully it will still be informative and useful. So we're going to be talking about achieving health equity in clinical research. I think it's probably safe to assume that most people on this call believe that it's important to have representative samples, but I think we disagree on why that's important, how to implement it, and of course, we still have yet to figure out how to quantify those efforts to really know whether this is effective or not. I just wanted to quickly just present my disclosures. I'm only supported by one pharma company, and it's Otsuka. All of that money is firewalled away from our research and kind of personnel grants or support and salary. And so this only goes to our community events. We mainly spend this money on swag and speaker fees. My research is supported by various ICs within NIH, very, very general support from the Michael J. Fox Foundation and Mass General Hospital. So we're actually going to take a little bit of a detour. This is going to be a research talk, but I believe that because this field that I'll be describing is so nascent, it's really better to begin with a little bit of philosophy and a little bit of history. So this quote is, I think, almost cliched in the public health world and when we're talking about disparities. It's of all forms of inequality, injustice in healthcare is the most shocking and inhuman. This quote was uttered by Martin Luther King way back in 1965 at the end of the Selma marches. Fun fact is that this quote was actually very controversial in terms of its precise wording until about 4 years ago. It turns out that I knew a colleague of mine here in Boston was in the stadium when MLK said it and was able to kind of put the record straight on exactly what these words are. So what's important to know is not just this phrase and not just what it implies, but MLK was actually talking very specifically about an injustice in healthcare that's familiar to all of us. So he was talking about access to health and health information, but he was also talking very directly about the Tuskegee syphilis study. which I think everyone has heard of, but maybe doesn't know a whole lot about. But just the cliff notes are that from 1932 until around August of 1972, the United States Public Health Service monitored about 600 Black men, half of whom had syphilis. They denied these individuals treatment. They did not permit them to receive care anywhere else. They lied to these individuals, and they were told that they had something called bad blood, which is not a real thing. They were told that they were having their bad blood treated, which also was not a real thing. So these syphilis victims spread syphilis to their wives and kids. About half of them died of syphilis-related causes. So this is a real dark moment for clinical research. But what I'm going to show you now is a brief video from a PBS Nova special from 1993, which was recent enough to the Tuskegee study that, excuse me, some of the original research or study doctors were interviewed. So there's one interesting quote that I want you to listen to here. And what I want you to try to listen to, and so because this is Zoom, the video is not going to be great, but the audio should come through, is just listen to the words that this study doctor says, justifying the Tuskegee study. And then I'm going to make you all uncomfortable. I want you to think very carefully about whether you could use a similar justification today in the way that we talk about our research studies. So the video should come up here. And again, the video quality is going to be grainy, but you should be able to hear the audio.
One of the few surviving public health service doctors who worked on the study still defends that decision, John Cutler.
It was important. They were supposedly untreated, and it would be undesirable to go ahead and use large amounts of penicillin to treat the disease because you'd interfere with the study.
So for those of you who may not have been able to catch that, Dr. John Cutler, who looks very much the part of any 90s movie villain, said that if we had given penicillin to the folks who could have been cured with it, it would have been undesirable. It would have interfered with the goals of the study. So for better or for worse, whether we like it or not, if we're going to be talking about a nascent field of recruitment science or engagement science, we have to start with something like Tuskegee. This is where it all began. And the justification for developing that detailed, complex recruitment strategy and the detailed, complex retention strategy is ultimately to serve our study goals. And what we ended up doing with Tuskegee is we forgot that we were working with people. It turns out that Tuskegee is not the only stain on our clinical research world. I'm not going to spend too much time on it, but here is an abbreviated list of other significant medical abuse against Blacks, between the 1840s and today. So if you look at the bottom of that list, you'll notice that some of those came after the implementation of the IRB and the Belmont report, which was implemented as the direct result of the Tuskegee syphilis study. So keep in mind that it goes far beyond Tuskegee and Henrietta Lacks. I actually have a talk that I could give, an hour-long talk, that walks through each and every one of these and a few others to talk about to the extent of the problematic way that we have used Black bodies to justify our scientific advances. Now, it's not just about these past medical abuses. So some of you might be thinking, you know what, that was a long time ago. I know better. My colleagues know better. We would never do anything like this now. We need to think about the current harms. What I wanted to indicate is that what happened with Tuskegee, what happened with these other studies that prompted the Belmont report, then created a cascade of other significant problems. So instead of me saying it, and because I know it's 4 p.m., I'm going to show you another video. So this is from a Vox and ProPublica report that talk about some of the current health disparities that we're facing and where those health disparities in part come from.
In a lot of ways, SIMS epitomizes the story of American medicine for Black women. It's a system that's failing them to this day. From infant mortality to life expectancy, the racial disparities in healthcare are staggering. The gulf between Black and white might be widest when we look at maternal mortality, with Black women 3 to 4 times more likely to die in connection with pregnancy or birth than white women. And that divide can be traced back to doctors like Sims, who contributed to a long, largely overlooked history of institutional racism in medicine.
Trying to understand a historical problem without knowing its history is like trying to treat a patient without eliciting a thorough medical history. You're doomed to failure.
All right, and so that's Harriet Washington, who wrote a book called Medical Apartheid, which chronicles many of the abuses that I kind of put on that slide earlier. It is a tough read, but I highly recommend it. We have to understand where we came from. And one thing that we often don't appreciate as researchers is that the current culture of health disparities, especially health disparities as a function of race, can be traced back to the two-tiered system of health research that we built in while trying to atone for the sins of Tuskegee. So what we have now is we tried to solve one problem and we have created others. And so when we are trying to intervene on disparities, we have to recognize that it is we, especially those of us who are in research, that in part created that system. Now let's talk a little bit about why diversity is important for clinical research. I think that most folks feel that it's important for maybe one of two reasons. One, it's important to think about the moral argument of being inclusive with our research studies. And then two, it's important to think about it in terms of trying to push for external validity or some kind of generalizability. It turns out that there are maybe some other reasons as well. With regards to that argument with respect to external validity, Ramamurthy and colleagues in 2015 published a report that said that 1 in 5 FDA approvals over about a 6 or 7 year period had some kind of differential effectiveness as a function of racial or ethnic group. And so this was not just for therapeutics, but this also included FDA approvals for devices during that same time period. Unfortunately, this particular report didn't look at other factors like gender or educational attainment, income, rurality, or anything like that we also might suspect would play a role. But it's important to think broadly about diversity because when we get to the post-approval phase, we're often left with these therapies, with these devices, with these biologics that may have differential efficacy. We know that in particular, our most advanced medicines and therapies are the ones that have the most kind of egregious gaps when it comes to representation. So precision medicine, personalized medicine, obviously if we're thinking about cancer, or even something like the All of Us research study, representation is still a major problem. But it's not just a matter of external validity. We also need to think about statistical conclusion validity and some aspects of internal and construct validity. We know that work by Elizabeth Rose Maeda, Jenny Weave, shows that there are these incredibly important but underappreciated selection and survival biases that can creep into our studies that completely skew estimates of our causal factors. And what's important to realize is that it skews those causal relationships in such a way that we don't know whether it tends to weaken them, unnecessarily strengthen them, render them moot. It can have any kind of effect on our data. And again, just talking about the validity of our statistical conclusions. So with that said, we need to keep in mind that diversity is not just important for diversity's sake, but also for the sake of high quality science. So those of you who may have seen some of my tweets on Twitter, I always talk about how recruiting and in being inclusive in terms of your diversity is another way of saying that we're doing our science rigorously. And it's these points that have been made by Maeda and Weave that really justify that particular claim. So let's talk a little bit about what happens if we don't recruit diversely. What does that look like? And how is it possible that we can potentially understand where that's coming from? So the FDA produces this clinical trial snapshots every year, and I do this every year. Nothing changes, so it's kind of a fun little magic trick. What you see here are the averages, across a number of categories. So what you can see is, by golly, it looks like the FDA is doing great when it comes to in being inclusive of women. They're doing really, really well with representation of Asians. Never mind that we don't have a clear idea on what Asians is. because who knows who's included in that category. We are spot on when it comes to Hispanics, by which I think they mean Latinos. We have, incredible representation across the age spectrum for those who are 65 and over. And so if you look at this, you might think that, by golly, we're getting somewhere. We are, truly living in a post-racial America. But it turns out that this is one of those cases where if you know your measures of central tendency and dispersion, you know that you should not trust a mean. So what I did was I also calculated the median across the studies, across the FDA approvals for last year. And what you can see is a pretty stark difference in exactly the categories that you might expect. So we are not doing nearly as well with women as you might expect. We are not doing nearly as well across our racial and ethnic categories. And then obviously when you look at those who are age 65 and over, there is a huge change in median representation across these groups. Now, not only do you see that the median tells a completely different story relative to the mean, we also have to keep in mind that we're missing a lot of data from these snapshots. We don't have anything in terms of intersectional data. We don't have great ideas in terms of sample sizes. We don't have anything about definitions of categories. We don't even have good data on missingness. So 27% of all FDA approvals in 2019 didn't report, just straight up didn't report one or more of these categories. Then, if you look at this last column where it says United States, it's talking about the proportion of individuals who did an FDA regulated clinical trial inside the United States. So if we have 60% of the folks who are outside of the United States, does it even make sense to have some of these categories? Particularly when it comes to identifying or clearly identifying what it means to be African, emphasis on the word American. Just for funsies, because I am a huge nerd when it comes to distributional measures, I also calculate the coefficient of variation, which is another way of calculating like a relative standard deviation. And what you can see here is that not only do we have poor representation of racial and ethnic minorities, you can see that for Asian and the Black groups in particular, that relative standard deviation is quite large, which means that some studies have a ton of diversity, and some studies just don't. So we have to keep in mind that the mean only tells us a fraction of the story. It's really important to look at other measures of central tendency as well as dispersion to understand the fuller picture of what's going on here. Now let's look at a study that's a bit closer to home. This is one of my favorite studies that was published in 2019 by Carrie Gleason and colleagues out of the University of Wisconsin-Madison. So they looked at individuals from the National Alzheimer's Coordinating Center dataset. Most of you might know that as the NAC dataset. Hopefully everybody recognizes a good old-fashioned Kaplan-Meier curve here. So this is individuals who had mild cognitive impairment. They had MCI at baseline. And what we're looking at over time, over their age, is the proportion of individuals that progress to full-blown dementia. And so what you see here, if you are feeling decently awake and attentive, is something that should confuse you. Because what we're seeing here in terms of the survival probability suggests that white individuals are progressing to dementia at a far faster rate than Black individuals. So any of you who have ever read anything about disparities when it comes to Alzheimer's and dementia know that this is wrong. This does not reflect the way that we should be thinking. This does not reflect our current data. And you might be thinking, well, heck, maybe they just mislabeled the group categories here. It turns out that they didn't. And it turns out that what happened was there is a really interesting conflation here in the NAC data set. So what they did in this really, really great, fantastic paper, please go and read it. I'll send it to you if you can't find it, is they found out that there was a conflation between race and recruitment source. So if you're looking at these and confused that whites are progressing at faster rates to Blacks, it becomes much less confusing if I tell you that the vast majority of white people were recruited from a clinic environment and the vast majority of Black people were recruited from a community environment. So if you think about the basal probabilities the baseline probabilities of simply developing dementia in those environments, what we're seeing here is kind of a relatively lower risk group in a clinic setting and a relatively higher risk group in a community setting. And the conflation of those is being attributed to race rather than recruitment source or environment. So we have to think that even in our field, the NAC data set is something that all of us contribute to, is that if we are not careful about how we characterize our data, and if especially if we're not careful about our recruitment science, we tend to open ourselves up to precisely this kind of risk. So naturally, the NAC data set is not necessarily meant to generalize, but it is meant to reflect the kinds of populations that we are likely to attract for our clinical trials. So again, we need to be very, very cautious of that. So the big question is, why can't we recruit diversely? I've listed kind of David Letterman style, my top 10 reasons here. And I think that, this is a kind of a selected set of references that talks about why this is the case. I'm not going to necessarily go over all of these, but one thing that is often missing from when we talk about our inability to recruit diversely, because I don't think any of these 10 reasons are a surprise, is whether there is like a relative ordering, whether it's more important to maybe address some of these rather than others. If you have limited time or resources, do you just pick one of these at random to solve, or are there ones that are particularly fundamental? So the work that we've been doing at the Care Research Center is basically saying, with those 10 reasons, it's possible to workflow them and to create an order of operations to help anyone get the most bang for their buck if they have limited resources, or to be careful and develop a clear set of quantifiable metrics and testing hypotheses if you have relatively more resources. So you can take those same top 10 reasons, and what you can do here is you can map them onto a particular workflow. As you can see here, so some of the reasons map one-to-one, some of the reasons map onto one of these areas of the workflow, and then others kind of map on, accordingly. So what you have here is you have a recruitment funnel where you first define your sampling frame, which is something that not nearly enough of us do. And then you work on building awareness, engagement, and interest before getting into the areas in the red box, which are part of our typical recruitment, our typical research workflow. Note that if we try to skip these other 4 stages, what tends to happen is they collapse and they have to be addressed all at once, usually at the point of screening or at the point of consent, which is what makes it difficult to recruit diversely. We're basically trying to combine 5 steps into one for a group that doesn't necessarily have the literacy to navigate intensive, complex research conversation, or they don't have the privilege to take the risk and skip it. So, what I think is really crucial that we have to keep in mind is that we have to address each of these stages individually, and we need to have a set of outcomes and measures for each of these individually. Now, I'm going to give you just a quick case study, and then we're going to move on to the much sillier version of my talk. So as I mentioned earlier, we are supported by the Michael J. Fox Foundation. There's the man himself. What happened was about two and a bit years ago, the foundation approached my research center and said, you know what, we have this online study, Fox Insight. You don't need to go into a clinic. You don't need to talk to anybody. You can just log on. It's mobile friendly. You can look at it on an iPad or a phone or a laptop or a computer. And you can participate in Parkinson's research because, one thing that we knew from clinic environments is that Parkinson's research is simply not diverse. Not just in terms of race and ethnicity, but a lot of other factors. So they said, we're going to remove these barriers for entry. They said, we thought that would give us all the diversity in the world because anyone can sign up for a Parkinson's study now. But here's what the data looked like in 2018. If you can't see the words there on the bottom, this graph is super white for a reason. What we can see here is that this digital study, Fox Insight, was not only relatively undiverse when it came to race, it was relatively undiverse when it came to household annual income. where you have, shockingly, a mode of the distribution in excess of $100,000 a year. So keep in mind, at the time of the study, median US annual income was about half of that, a little bit over $50,000. And it's not just in terms of race and ethnicity, it's not just in terms of annual income, but we also see that you might be sort of misled by a mode of the distribution that's at bachelor's degree, which is bad enough. But note that there are 3 categories after the bachelor's, which comprise roughly 40% of the population has a master's, professional, or PhD or equivalent degree. So you can see not a terribly diverse sample, even though it was online. So what we ended up doing was we designed a study, a really quick study that we ran across last year and finished up about a week before coronavirus hit the United States in earnest, where we focused on these first 4 categories within the workflow, where we encourage sites to develop their own solution to have a strong sampling frame and to work on identifying a specific population and a specific barrier that they were going to try to address. And so we encourage sites to develop a rigorous protocol for engagement and recruitment that was as close to on par for a rigorous protocol for the actual study. And so what we ended up doing was we funded 8 sites, 4 were control. We gave $45,000 to intervention sites and $10,000 to control. That might not seem like much money, but honestly, across multiple fields, this is by far the most that has ever been given in a study looking at recruitment or intervening on minority representation. It's about twice as much for intervention sites as any study that I've been able to find. So most of the interventions did focus on engaging community directly, as well as trying to educate physicians that are working at the level of the movement disorders clinics, as well as general neurologists. So we launched the pre-intervention study in September 2019. And what we found is that at the time that I wrote this particular slide, there was 20% lost due to digital language barriers. And I think when we finally looked at the data back in April, it ended up being about closer to 30% loss due to digital language barriers. Trust was not the factor that many people thought it was. And then sites with a clear sampling frame who knew exactly who they wanted to reach recruited very, very quickly. So here's the bottom line for this particular study. So if you look at baseline accrual to Fox Insights in the categories for these 8 sites, you can see that in gray, there wasn't much diversity across race, ethnicity, income, and education. We see, shockingly, that control sites who didn't do anything other than kind of put out some postcards talking about the Fox Insights study, they were actually able to substantially increase percentage of non-white accrual to Fox Insights during the 5-month study period. But what's really remarkable is that the intervention sites, even though they typically focused on one of these 4 categories, through their interventions were able to substantially improve diversity across all 4 markers. What's really remarkable, it's not as though they were able to reach, say, Hispanics and non-whites that were low income and low education. These are in large part overlapping but not isomorphic identities for the people who came into the study. So what I think was reflected here is that by focusing on developing a really robust protocol, you can actually substantially improve diversity accrual to even online studies that are typically very difficult to access. So what does this tell us about diversity? What's clear is that one place's solutions really don't necessarily work for another. They really need to be tailored or matched to a clearly identified set of barriers. Otherwise, it's not likely to work. We really need to recognize that the onus for improving diversity in research is on the study team. Now, I know that that is deeply unfair because the study team is often overworked and underpaid, but ultimately it's impossible to shift this burden to communities of color or to whatever sort of diverse community that you're looking for and expect them to make any sort of a difference. The last point that I wanted to make for this particular slide is working with communities is always a good idea. For this particular study, for the Fox Insight study, it had been fairly well established within the Parkinson's literature that working with communities was not a good idea because Parkinson's is relatively a disease of low prevalence. What we, I think, have really, again, early data to indicate is that it's always good to work with communities, even when you have diseases that are rare or low prevalence, because the experts are in the community, and you're not just trying to surface cases of individuals living with the disease, you're trying to find surface experts who can tell you how to reach these individuals in ways that are really tough to identify. So in terms of thinking about what's next for a science of recruitment or a science of inclusion, I have millions of ideas. So if you have a good idea and you see something on the slide and you want to steal it, please steal it. I don't need credit. I've got enough to do, but there's a lot of really cool ideas here that I'm eagerly pursuing. So if any of these speak to you, then definitely let's talk. The other thing that I think is really crucial in the early phases is to think a lot about comparative effectiveness and non-inferiority research about specifically this recruitment, engagement, and retention process, because we want to understand, given a particular set of constraints, what's the best way to move forward. And then finally, I would love to kind of examine this workflow model that we are testing in lots of other environments. And then my super big goal is to kind of start to de-silo information and democratize research out of universities and academic medical centers. But that last bullet point is sort of my Viva la Revolution kind of idea. So it'll be a while yet before we get to anything like that. So that is a super quick version of this talk. I'm gonna pause and invite any questions while I switch over to my next slide deck, which is a little bit more about my personal career development. So thanks so much for your attention, and hopefully this was interesting.
Yeah, thanks so much. It was very interesting, and everyone is welcome to ask questions in the chat, or even oh, there's already one actually. Well, Stephanie, if you want, you can unmute yourself and ask it directly.
Thanks, and thank you for the talk, Dr. Jackson. It was very interesting. My question is about diversity in researchers themselves. I am Mexican, and I have seen that a lot of the interest in having research in the Latino community comes from other Latino investigators. So I wanted to ask you, how much can you see diversity in researchers to push this forward?
Yeah, so this is an area that I deliberately did not talk about in this presentation because I worry that non-diverse, let's say kind of majority folk, are kind of obsessed with this idea that if we get more diverse scholars, then they will do all the diverse research for us. And I think that it's important to allow folks who are diverse to choose their own destiny. And we'll be getting into this for my second part of the talk, but I had zero interest in diversity. I did not care about disparities. I was like very much a quant guy. I did really, really awesome measures of attentional control. And then through, some supposedly gentle nudging over a number of years, I ended up doing this. And so I'm still happy doing this, and I'm doing it on my terms. But we have to be careful when we talk about the need to bring in scholars of color to do work on communities of color. I think that perspective is crucial, but I do think that the scholars of color should choose that destiny rather than having it forced upon them. Any other questions, or should I jump into the second?
Hi, Bruce Miller, a quick question, but I bet the answer isn't so easily done quickly. Thank you very much for an incredibly valuable lecture. I really appreciate it. A few words about democratization of research. What lines are you thinking around, and how do you think we should start to take steps in that direction?
Yeah, so super quick answer. I said democratization of research. That's because it's the less scary word. What I really mean is decolonizing research, which I think makes people uncomfortable. But what I mean by that is recognizing that we need to recognize and reward and structure around different sorts of expertise. So right now, the way that we normally run our research labs is that you get somebody who's got an advanced degree, an MD or a PhD, or, my goodness, somebody's got both. And they are in charge of a group of people. But they are in charge of a group of people because they're good at science. They're not necessarily good at all the other stuff that comes with it. So we can think about that very narrowly in terms of just like day-to-day operations, managing a budget, managing a people. A group of people. But what I mean is thinking a little bit more carefully about data ownership, thinking a little bit more carefully about who is actually in charge of approving research protocols, especially when you are sampling from any kind of convenience sample or even a community-based sample. So some ideas for doing that are basically taken from the way that we have responded to native and indigenous cultures, just because of the Havasupai and a few other nasty things that we've done. Community IRBs, community data ownership, would allow individuals, especially who are marginalized or vulnerable in some way, to have more of a role in the development of research and the approval of research, and in the ownership of research data. I do want to standardize and normalize return of results. It doesn't have to be, you don't have to return results from the specific study question that you have. You can return results that are of interest to the population that you're studying. Usually you can run like an additional blood test that's not very expensive, but would be infinitely valuable to the group that you're studying. I think that's really crucial, ultimately, to move research entirely out of academic research centers, where communities can kind of own the research process. They can define their own questions and they can answer their own questions by generating their own data. And ultimately, academic medical centers can support these efforts, and then we can be free to answer either bigger or more complex questions. The idea is that academic medical centers don't need to do all of the research. We just need to make sure that the research gets done, and we need to support people where they don't have the tools, but otherwise just leave them to it. And because there's plenty of science to go around. So that's the super quick version, but the idea is that science needs to happen outside of universities and medical centers.
Thank you.
All right, so I think we are starting to run low on time, but I want to get this other slide because it's a big change of pace, but I think it's perhaps more important than the other talk that I gave. So I'm gonna share now.
And anyone, I'm just gonna say while you're shifting, I would say don't rush on, just do your thing. And if people need to step off, they can. And the good news is there's no rustling of chairs or doors slamming. So we won't even notice. But there will be a video of this available later, so everyone can catch up.
All right. So the other part of my talk is sort of focused on career, and my career in particular. And so I wanted to present. So this is a talk that I often give to undergraduates and high school students. Because I am a recovering overachiever, and maybe not that much, maybe I'm not really recovering. I am an overachiever. So I was one of those kids who did really, really well in school and was really, really scared of messing up. When I was in 3rd grade, I got a B, one of 2 Bs that I got in my academic career. I got a B in 3rd grade and I didn't go home for 6 hours because I was scared of what my mom was gonna do. So we know that there are lots and lots of people like us in academia, and I think that we need to embrace failure a lot more than we do. So I'm going to talk a little bit about what I mean by that. So normally we are very much in this culture of success, where we have this idea that men are born to succeed, not fail. Not sure what Henry thought about people who weren't men, but let's just assume that everyone is born to succeed and not fail. If we want to be like this beautiful dog here, sorry, there's no cats in this presentation. That if you believe, you will succeed. We know that, even our storied Marilyn Monroe lives to succeed, not to please, you or anyone else. We really do have this culture that embraces success. This culture that even talks about, working and striving and struggling through failure to get to success. So, when we talk about, the famed examples of these individuals here, maybe in light of her recent comments, we won't focus too much on this lady. But the other 7, are all kind of, world-renowned for how much they failed before the fact that they ultimately succeeded. I'm not talking about this either. I don't want you to sort of co-opt this mystique of failure on your way to success. Instead, I really want to talk about trying to get over this fear of failure, this fear of imperfection. And what I really want people to focus on is being less like this and being more like this. When we talk about failing, I really want to encourage you to just mess up. To basically start looking at these people as your heroes. Oh, I was wrong. There is a cat that's having water dumped all over it. So great. But what we have here is the goal, is to really fail in big ways, sometimes in incredibly stupid ways. And in order to understand that, we need to look at Exhibit A, which is me. This is me in, I think it was 2003. There's a chance it was 2002. It didn't matter because that is me, giant dork extraordinaire. I thought I looked really, really good in that visor, and I wore it for far too many years. But like I said earlier, I was very much your classic overachiever. But there was just one problem. I grew up on a farm in Texas. Nobody really knew anything about life after high school. Nobody in my family, of course, had gone to college. Nobody had gone to graduate school. I didn't even really know what that was because it wasn't even something that people talked about on one of the 3 channels that I got growing up. So around Thanksgiving of my senior year, I went to talk to my guidance counselor, and I was just like, hey, guidance counselor, I'm thinking about going to college. What should I do? And he responded, he's like, you know what? It's good that you're thinking about this. You should look on the internet. And that was the totality of his advice about going to college. So what we ended up doing was, this was me, age 4, but let's talk about January 2nd, my senior year in high school. So I cried in this picture for like many hours because that suit was so itchy. It's one of my earliest memories, actually. January 2nd, senior year of high school, 4:55 p.m. I had finished my one and only application to Rice University. So Rice University that year had a 17% admission rate. And because I was, Jonathan Jackson, I was very good at math. I thought, well, I'm 3rd in my high school class. So that means that I'm in the top 17%, totally gonna get in, fine. And so what I did was I filled out the Texas Common Application because I looked them up on the website and they said we accept the Common Application. So then what I ended up doing was standing in line at the post office 5 minutes before it closed to apply regular decision to one and only one university. I didn't apply, I didn't have a safety, I didn't have a backup, I didn't even think about going to a local community college. I just turned in my Texas Common Application and sent it. 3 weeks later, believe it or not, 3 weeks later, I got a letter in the mail from Rice University, and I was pretty much like this. I was really, really impressed with myself, my overachieving ways. I had managed to win my way into one of these prestigious universities, and I had done it at the last minute with no help from anybody. And got it in, with 5 minutes to spare. But all of that was before I opened the letter, which actually said that they did not accept let me pull this up for you so you can kind of see. They didn't accept the Texas Common Application. They accepted something called the Common Application. Never mind the fact that there are 2 things called the Common Application. But what they did was they gave me 2 weeks to resubmit the Common Application. And so basically what happened was January 31st, my senior year of high school, I was, just to recap, had applied to one school with the wrong application. I had no backup options, and I was feeling really quite stressed at this point because there was no one I could turn to. There was no one that could really help me. I was just left to figure this out on my own. However, I did manage to resubmit the application. I got in, and I remember talking to the admissions committee my senior year of college, and I said, you know, I did this really silly thing. I submitted the wrong application. You know, I bet that happens all the time. And there was like this shroud of silence fell over the admissions committee, and they said, that was you. And then they proceeded to laugh at me for like 10 minutes because apparently this is not something that routinely happens. And I think to this day, I remain probably the only person who has ever submitted the wrong common application to Rice University. So when I got to college, because I was an overachiever, but overachiever in the regular way, I didn't know how to study. I didn't know how to do anything, and I was really bad at it. So let's go over a quick list of the things that I did poorly my first semester in college. In Math 101, I thought I was pretty good at math. My school was too poor to do APs, but I thought I would have gotten an AP in math. I got a 10 on my second Math 101 test. It was out of 100, so that was a really poor performance. I decided that I wanted to be a psych major and you know, wanted to be a gunner. And so I sat in the second row. I was the only person sitting in the second row for this large lecture course, and I definitely fell asleep every single class. And I do snore. And then I decided to, you know, take a new language, and I got a D- in my Japanese 101 class. The only reason why I didn't fail is because I think the teacher just felt quite sorry for me. And then in my philosophy 103 class, I only asked one question on the last day, which was how old the professor was, because I couldn't tell. He seemed like he was like either 30 or 50, and I didn't know. And he actually didn't give me an answer. I mean, I guess it wasn't my business. But it was the only contribution that I had the entire semester. So just to, again, to recap, in college, I was awesome. But moving on to graduate school, we know that college is tough. Grad school is even harder. And I didn't do well here either. You know, I was the kid who overpromised and underdelivered on every project. I actually had to leave graduate school after 3 years after doing a very poor job during my master's thesis. I couldn't even get a job. And so then I failed my way out of failing out of graduate school and failed back into graduate school after about 8 or 9 months. You know, we were talking about this earlier. I was the person who routinely put faculty to sleep during talks. Again, these were academic talks that I was very excited about, but I was really, really good at putting a sizable portion of the audience to sleep. And my actual dissertation, the reason why I have a PhD, is 125 pages of stuff that just straight up didn't work. This is not cherry picking. This is not, you know, me being falsely humble. If you ever run into my dissertation advisor, she's definitely going to just sigh and be like, oh, that guy. So again, you know, I failed, and I failed my way. You know, part of my journey was that, you know, in my goals, I was really obsessed with this idea of working in Risa Sperling's lab over at Harvard and Mass General. I've been obsessed with it since shortly before I started graduate school, and I kept trying to apply. I kept trying to intern. I kept trying to volunteer. I kept trying to collaborate. I applied for postdocs starting in 2010, in 2011, and 2012. And they kept telling me no. Eventually they told me yes. And I was deeply excited about this, but it turns out the only reason why they told me yes is because I promised to help them out with minority recruitment, which in hindsight was maybe not a great idea. You know, if I couldn't get in on my own kind of academic merits, being a token brown person was my way in. So as you might have expected, I failed at this too. So like I said, I really focused on the neurocognitive markers of attentional control. I thought I did some genuinely fantastic work at Arisa's lab, but if you actually look up my publications, none of it was ever written up and submitted because nobody cared. couldn't get anybody to care about it. You know, the data's still sitting there. I published too slowly. I still publish too slowly. I have way more data and projects than I should. You know, I think most notably there was a very difficult cultural fit with my colleagues there. You know, I think that if you ran into my colleagues, you know, today from this time, they are very likely to say something along the lines of, we wish Dr. Jackson the very best, but we have no further comment. You know, so ultimately, it was really tough being in this particular system. And I think one of the hardest failures on this list is, you know, when we're very, very, very lucky or very, very, very unlucky, some particular kinds of failures may indicate that the system itself is malfunctioning. So the fact that I had a really difficult cultural fit with my colleagues in that group, and the fact that they often told me that I spent way too much time in the community was really what helped me kind of open up to this idea that failures are important. So, you know, this is me, again, not in 2017, but honestly not long before. You know, what I recognized was that the way that I had succeeded previously, because we haven't gone over my successes, is that those successes didn't matter. They weren't working. I was doing what I thought was best. You know, I was trying to stick what I was used to or what I was good at. But you know, at the end of the day, what I was starting to recognize is that the way the system was set up, for somebody who looked like me, kind of doing what normally happens, it wasn't going to work. It wasn't going to get me very far. And what I started to realize was that in my particular research, the gains that we were facing and that we were seeing in medical science were ultimately not going to be felt in lots of places that I was hanging out in, especially in those community settings. So I got in trouble a lot at work for not being around to be the token Black scientist. So I was a failure, absolutely 100% a failure. But part of me thinks that, you know, what that indicates is not necessarily my lack of worth, but rather that there are some systemic changes that need doing. So, you know, when we think about forecasting, sometimes, you know, we get it completely wrong, and we are on the entirely wrong side of history. Other times, we have the opportunity to draw the map. I think that for lots and lots of people, they're in this position where, you know, the past seems relatively inevitable, it seems fixed. What do you do when you're overwhelmed with options and you don't know where to turn? You know that you need to make a decision, but you don't know which one decision is the right one. And I know that there are some of you, because again, I did study attentional control, who are distracted from what I'm saying now and are desperately looking for Waldo. I am going to either cause you massive anguish or massive relief by telling you that our boy is right there in the lower left-hand corner. So what I want to just kind of sum up by saying is it's good to fail. And I don't mean failing on your way to success. I don't mean avoiding failure. I mean just try and screw up, because what it does is it's deeply informative. It helps you understand the system and the context that you're in ways that success never could. And what I wanted to say is that in 2018, I ended up leaving that lab that I was in, and I got some funding from Harvard and from Mass General and from the community, and that was what enabled me to start the CARE Research Center. I've got just a couple of slides left, because my journey's not over. I'm still messing up, still publishing way too slowly. My first year and a half, I was a terrible leader at CARE. Like, I was a nice guy and wasn't mean to anybody, but my leadership style was completely ineffective. I was and remain very slow to pursue academic promotion. I'm qualified. I should be at a higher rank than I am. I just can't be bothered to do the paperwork. And then, you know, fourth and most importantly, I have no idea what I'm doing. There's no roadmap for this. You know, I write a lot. I shout opinions on Twitter. I do a lot of work. I do a lot of collaborations and consultations with research scientists. I think that it's making a difference. But in the end, history may not remember me kindly. But for now, I just want to say, you know, if you Google Jonathan Jackson, I'm everywhere. So I think that this is kind of the perspective that I wanted to offer. And I wanted to remind people that failing is always a good thing. It's always a productive thing. And it's always a useful thing. And we don't necessarily need to co-opt the lessons of failure into a narrative of success. So then you could be like me and hopelessly overshadowed by an older, much more famous Jonathan Jackson. All right, so that's the end of my talk. I hope people enjoyed it and that you learned some valuable lessons about failing and screwing up. I'm happy to stay on for a couple more minutes if people have questions or comments or feedback. But thanks everybody for your time.
Great, thank you so much. I can see a lot of thank you notes in the chat for you, and I'm sure that a few people are going to contact you privately afterwards.
Feel free to reach out.
That's fantastic.
Yeah, that was wonderful. Thank you so much.
Susan let me know that she has.
I don't know if there's any question. I think people can unmute themselves and ask them out directly if they want, because the chat is really active right now.
Yeah. Hi, Dr. Jackson. Thank you so much again. Really appreciated. Love the cat pictures, even though there was only one. No, really, thank you so much for sharing such a personal story. It really is really powerful, I think, for many of us, particularly those coming from diverse backgrounds, you know, and trying to figure out our way in research. I was just wondering if you could share perspectives on, do you feel like, you know, throughout your career, do you get a sense that the academic culture is changing at all? Like, are we moving in the right direction? You know, there is more and more, for example, NIH funding for diversity research, right? Both in terms of recruitment and also like implementation of strategies. But from an academic culture perspective, it would just be really helpful to hear what you think. Thank you.
Yeah, oh boy. So I think that we have a little bit of a problem of blind spots in academic culture. You know, part of the problem is that one of our measures of success in academic culture is how exhausted we are. You know, we kind of reward and celebrate the glory of overwork. And it, you know, turns out that folks who are really privileged can do the overwork and they can feel tired, but they also have a chance to recover. Folks that are less privileged have to give in just as much that glory of overwork with less success and with less, you know, with fewer opportunities for recovery. I think that we need to move beyond that in our culture. I think some of us have a chip on our shoulder that we don't earn as much as people in private industry. And so we just have our purity of the science and the fact that we are willing to, you know, put in 105 hours of work per week. And, you know, those softies in private industry never could keep up. You know, I think that that's a dangerous, toxic perspective. And I think that is behind why it is so hard to be somebody from, you know, a minority background, a disadvantaged background, even coming in as an immigrant. It's why it's so hard. You know, there are other major problems. You know, we know that academic culture is hopelessly sexist, hopelessly racist, and those ideas need to be pushed aside. But there's an underlying culture that NIH can't touch with funding opportunities, and that's the way that we run our labs. We give entirely too much power to one PI at the top of the structure, and if you make that PI mad, or if you don't do what that PI wants, then you don't get that letter of recommendation, you don't get that mentorship that you need. And so it creates a very, very precarious structure. It's very much based on the old apprenticeship model, which is, I think, a bit outdated and a bit problematic. So these are questions that I think many of you who are still on the call might be thinking are inherent to the nature and culture of academia itself. We cannot possibly change these things. But I think we can. You know, before I got into all of this, I was an agitator with a group of rebel postdocs that called themselves the Future of Research. And we talked about new ways of modeling and developing this work. I think that we need to have some radical ideas of how to do that. Part of the reason why I failed so badly in my first 18 months of being in charge of the Care Research Center is that I I was reacting. I was trying to completely reject all of those narratives and all of those possibilities. And I was trying to be an anti-leader. I didn't want to tell anyone what to do. I wanted to like have people go with their feelings and feel really included and accepted. And it turns out that everyone just felt super lost and frustrated with me anyway. So I'm not saying that we need to kind of like throw everything out, because I tried that and it doesn't work. But what I am saying is that there are lots of things that we feel are inherent to the culture of academic work, especially when it comes to this kind of research that we know will save lives, where we have to be a little bit more person-centered, both in terms of the people that we're studying and the people who are doing the studying.
Thank you so much.
All right. I'm happy to stay for more questions, but I don't want to keep anybody that has other plans.
Dr. Jackson? Hey,
yes.
Enzo.
Yes, Jonathan, please.
Nice to meet you. It was great talks. I had one question. So I'm not from the US. I grew up in a migrant background in Germany, where I never had to worry about access to education or to health because it's universal. And when seeing what's going on here, one wonders whether, how much of the difficulties in having, to diversify academic research are based not on the academic institution themselves, but really on a more systemic way that people that don't have the means don't have access to education and to health as they should. It's something that has been frustrating me a lot. I don't know whether I'm maybe over-emphasizing certain things based on where I come from, but yeah, I'm wondering what your perspective is on this.
Yeah, so I think there's a lot packed into that question. So the first thing that I want to say straight off is, when you think of like, the myth of the lone genius, the people who have really advanced their fields. You think of the Feynmans and the Einsteins, and the folks who are the giants that we stand on the shoulders. The one thing that they have in common is that even though some of them came from tough backgrounds, they were all relatively privileged people. And the thing that you should think, and the thing that I hope all of us think, are for every white Newton, for every kind of white adjacent Einstein, for every kind of white adjacent Feynman, how many non-men, how many people of color in lots of other environments could have made just as large or more contributions, but frankly weren't given the chance because of some of these systemic factors. The fact of the matter is, the reason why I think it's so important to democratize or decolonize research is because I'm greedy. I'm greedy for those ideas. And if we can move some of the way that we do research out of academic medical centers and out of universities, that gives us a chance to steal these talents and these brains for science and for scientific discovery. If we kind of change the way the pipeline works, and we don't make ourselves the end goal and everything else a black box, then that gives folks a chance to contribute in other ways. Now, the other part of your question is why do we have such a broken, fragmented system of education and health? And the answer is racism. When we were building out these resources in the United States, as we moved from a loose confederacy to a union, we wanted to give these things to everybody. Meaning the people that we liked, but we didn't want to give it to the people that we didn't like. So we created all of these complex rules. We tied insurance to employment and only sort of kind of white collar, high level employment. We tied education to median property values and income so that individuals who are privileged and rich could have good quality schools, and individuals who are Black and poor wouldn't have good quality schools. The idea is that, it's sort of very naked racism drove so much of the infrastructure that we have today in the United States. And it's terrible. The infrastructure is terrible because it was designed to benefit a very small segment of individuals and exclude everyone else. It is literally written that way. And so what we also are seeing is that by denying access to good health and good education, you're creating this system where individuals who look closer to me are more likely to be sick, they're more likely to die, they're less likely to have these kinds of opportunities. The fact of the matter is, someone who looks like me is far more likely to be in jail right now at any given moment, because I'm in my 30s, and if you look at Black men in their 30s, about 20% of them in any given moment are in jail or in the justice system. When it comes to Black men with PhDs, we are very, very rare birds indeed. And so the reason why that's the case is because we've designed the system to function this way. And I know it sounds like a weird, crazy conspiracy theorist thing, but unfortunately the receipts are there. Not only were these systems put in place, but nobody was particularly subtle about hiding them. So, we have practices about redlining, practices that I've mentioned earlier about accessing health and education, that are very clearly designed to benefit a privileged group to the exclusion of less privileged individuals. So mostly that was Black people, but we also recognized that a lot of other folks got caught in the crossfire. People who are new to the United States, people who are undocumented, people who are just poor, people who are in rural areas. All of these individuals are also caught in this same crossfire. And I think as Karen is saying in the chat, we created this myth of meritocracy. And I think more broadly, we created this myth of individual agency. And we said that individual agency is stronger than these systemic factors. And so we can create these systemic factors which are largely invisible in America. We don't think about them. We don't consider them. We discount them. And we say everything is at the level of the individual. So, we talk about these false meritocracies, and we fail to appreciate that there are systems that really contextualize whether we have a meritocracy. So that's true in the narrow sense in academia. It's true in a broader sense when it comes to success in America. And it's true in the broadest sense in terms of the systems that we've designed in this country. It's hard to talk about this without sounding like a radical, but the truth of the matter is that in our science and in our daily lives, we need to be more aware of systems of influence rather than individuals. And I think that is the next big step that we need to take in our clinical research as well. And that's a really important reason why we need to think about being more diverse in our research samples. Other questions or comments?
I see a lot of clapping, and and you've managed to keep more than 50 people, like almost.
Yeah, I'm deeply impressed. It's 15 after the hour, and so many of you are still here. Like, what are you doing? What are your lives like that you'd rather be here?
Any parting words of advice for the young folks who are going to be leading that edge of trying to decolonize research?
I would say do it, but I would say don't go it alone. If you need someone, please reach out to me. Sometimes I can be a little slow on email, but I will get back to you. I think that this is probably the most important idea that we have to pursue. It's way bigger than anything that I will ever research. And if we can work on decolonizing the way that we do academic research, I think that we can make such a big difference across a wide range of health and health adjacent outcomes. So please pursue those ideas. And if you need support, reach out to me.
Thank you.
I think Lynn asked a question about any recommendations. Yeah, I think we will all read Medical Apartheid now, even though it's sold out on Amazon and it's #1 in medical ethics on Amazon, apparently. So that's a good sign. But yeah, if you have any other recommendations.
Yeah, given what's happened in June, I'm sure it's been on a bunch of lists. It's worth the wait. And it's a tough read, but I do encourage people to give it a shot. In terms of Rex, I think, so Ibram Kendi is coming to Boston, which is very exciting news. I don't know what he's going to find in Boston. Boston is a tough place. So I think Ibram Kendi has done a lot of recommended reading. I think he's even put up a reading list on Twitter. These are all very, very good ideas because unfortunately too few individuals who are involved in our line of research consider these kinds of things. So it's not just about thinking about the history of medical research. It's about thinking about kind of the history of how the United States is structured and how we are set up to do this research as well. So I would certainly defer to a lot of the reading lists that are floating around. I would also, okay, one last thing is, there is a civil rights activist that I always talk about. Her name is Septima Clark. If you read one thing, just go and read like her Wikipedia page. There are a few biographies on her that are amazing, but just read about what she did and how she was able to build a culture where 700,000 Black and African Americans were able to vote. You know, it wasn't just a matter of driving them to a voter registration drive. It wasn't a matter of like taking them to the polls. There was a whole system of building empowerment and literacy that I think we need to adopt and we need to use, you know, in our own work. So I would recommend reading up on Septima Clark and trying to leverage her principles.
Thank you. I anticipate, as Renaud said, you'll probably be hearing a lot from folks who've been able to attend the talk, and
yeah, please do.
You'll
please
get
do.
an additional virtual audience in the future as well. So thank you again for taking the time. You know, it's like after 8 o'clock where you are, so we really
it's getting dark in here. I don't know if you guys can tell, but yeah, the sun has set over here.
And perhaps we can continue our conversation again soon if you have the time. Obviously not too soon, but you know.
Yeah, happy to return and speak to everybody again. This was great. Thank you so much.
Thank you.
All right.
Bye,
Bye everybody. Take care.
Thank you.